Yeah. I'm like, phew.
I might share my screen if that's okay with everyone. Let me just get the one I need. I know your email might say, oh, hang on, let me just get rid of that. I think the email said valvular disease, but we're actually not doing that today, everyone. So sorry if I'm
Surprise.
really excited about valvular disease. But what we are doing today with hypertension and pericardial disease, I think it's really good because I think, if you agree, Anna, I think it's really examinable, hypertension, particularly given there's a consensus statement on it. It's really common in practice. So I think it's quite a fun topic to to give some time to today. Can everyone see my screen?
Yes.
Mhm.
Okay, perfect.
Mm.
Morning, Julian. Hello.
Hello, sorry, I'm late.
Yeah, yeah, it's better. So yeah, as Jeff was saying, Olivia, we're very happy you can join us live, and please feel free to jump in. It's as interactive as possible, so please feel free to stop me, jump in, say whatever you want during.
Thank you. Yeah.
Um, so everyone that's studying, hopefully you've using the consensus statements, which I think are quite a nice guideline to go through for study. And there's a 2018 consensus statement on hypertension. So I thought we could kind of go through that together to start with. Um, Obviously we all know. Are you guys in the way? Can you see this little guy of all of you?
Yeah.
Yeah, we can all adjust our settings so
Right,
we
okay.
can maximize
I'll put you
that
down
or
there.
minimize that. Yeah.
Um, So I know I've got some up here, but I thought we could talk about some of the most common um, TODs that we see in practice. So what do we mean by target organ damage?
Well, all those things that are there.
Hmm. So
So,
the
um,
The thing their high blood pressure is going to affect
yeah.
the most. Yeah.
Yeah, so the
Yeah.
organs that are consequences, particularly useful if you've got an owner that it's like, well, it doesn't really matter. Um, so the organs that have got little fragile capillary beds, so the glomerulus is such a good example of that, where you've got this fine little complicated glomerulus capillary bed, that we'll talk about in more detail. The eyes, as we all know, the brain, both from capillaries, but also the brain's more susceptible to other consequences of hypertension. So, like ischemic injury, you can even have cervical spinal myelopathy from hypertension. And the heart affected in a slightly different way because if we've got increased systemic vascular resistance, we're increasing our afterload, of course. So we're going to lead to left ventricular hypertrophy, particularly in cats, like we spoke about with the cardiomyopathies, hypertension being one of our HCM phenotypes. So, meaning a disease that completely mimics true genetic HCM. So, on echocardiogram, when we do an echo of a cat and we see what looks like HCM, that's indistinguishable on echo from true HCM, that the patient's got a genetic HCM, or the phenocopy, with being left ventricular hypertrophy secondary to systemic hypertension. Does that make sense?
yep.
Yeah.
Yeah.
And what's the other phenocopy? I'm going to pick on you, Julie, and I'm sorry because we've spoken about it. What's the other that you would need to screen for in cats with HCM? The other phenotype?
Hypothyroidism.
Yeah, hypothyroidism. Amazing. So the consensus statement, I think this would be quite a good examinable question about how to take it. It sounds simple, but there's really good guidelines in the consensus statement. Letting your patient settle, having a really appropriate cuff size. That's, as we all know, that's 40% when you hold it against, if you've got the patient's arm and you're putting your cuff this way, that's 40% of the limb. Taking several readings in a nice quiet environment. And what we typically do in practice is do it at the start of the consult when the owner comes in, particularly for cats. Leave the owner in a nice quiet consult room with the cat out of the cage wandering around for 5 to 10 minutes, and then go in and take your readings. Does anyone have any top tips for taking blood pressure in patients in practice and trying to avoid this situational hypertension?
I was just wondering about, I've always read that you should take it straight away. But then I also find the cats have just been in the car, they hate it, they're all stressed about it.
Yeah.
So I'm always like, do you take it straight away? Because they'll be more likely to have higher blood pressure.
Yeah.
Don't know.
That's a really good point, Livia. I guess by straight away, I mean before we've done bloods or faffed around with them doing other
Oh,
things.
true. Yeah, yeah.
We try and have the owner in a room with the cat's out of the carrier, wandering around the room for 5 to 10 minutes. Particularly if you've got a consult room that's quite good for, with like a little cat hidey hole or somewhere that they can sit and be with the owner. We'll use a lot of those cat crack like licky treat tubes, that look like a
Yeah, they're great. We call
brood.
them
Yeah.
kitty crack. Yeah,
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 try and have the owner sort of sit with them for 10 minutes. So I guess it's kind of getting the balance between
yeah.
as quickly as possible, but not not as soon as they walk in the door and a Labrador's been barking in their face in reception,
Mm.
ideally. Yeah. And a good part of the consensus statement also is not making too many decisions on a one-off reading. So, even if you do all of these things that we've outlined here, beautiful environment, owner there, and you're still getting high pressures, it's going to change your decision making if you look at the patient a little bit. So what I mean by that is if you're getting consistently high readings, what sort of things impatient factors are going to make you believe that reading versus think maybe this is situational and I might retake it at another time? I don't know if I've asked that right.
As in, if you do all your other tests and you're seeing target organ damage or
Yeah, absolutely.
on physical exam
Yeah.
evidence of issues.
Absolutely. So what specifically, so say we've got a 12-year-old cat in for routine vaccination. The owner has reported no clinical signs or anything they've been worried about at home, but it is an outdoor cat. You take a blood pressure reading and you're getting consistently 160, and your physical exam is entirely unremarkable.
Just, I guess, looking at the body language of the cat, like, is it completely freaked out? Like, is it actually representing what it would normally be at
Yeah.
home? Yeah.
Yeah, I think
Like,
that's
if it was totally chilled out, not worried about anything, just flopped there, then you think, well, actually, that's true.
Yeah, I
Yeah.
think that's a really good point. Body language
Mm,
is so
mm,
important. And
mm.
conversely, if we had a cat, same signalment, a 12-year-old indoor-outdoor cat that came in for subtle behavioral changes at home, and you haven't performed your physical exam yet, but you were getting a hypertension reading of 165, what might you want to do next? What are we thinking?
More diagnostics? Is that where
Yeah.
you're going to?
What would you like to do?
Can we do a CBC and biochem first?
Mhm.
Um,
And why would you like to do them?
I guess if your cat is just coming in with just broad changes in its demeanor, you want a CBC, obviously, if you want to see anemia or if it's got a leukocytosis or an infection going on.
Perfect.
And then your biochem, I mean, we're talking about hypertension, target organ damage, but either way, you might want to see whether it's got hepatic disease or like a hepatic encephalopathy, or whether it's got renal disease. So in this case, with the target organ damage refer azotemia. And then it depends what the owner describes as changes. What are the changes in its behavior? Is it going to its litter tray more often? So has it got PPD?
Yeah, lovely.
Or is it like licking more often? Could it have like ulcers or anything in its? Did we see anything on physical exam?
What sort of things would you want to look for on physical exam, specifically worrying about hypertension?
I guess you want to check the pulses, check for peripheral perfusion and how the limbs feel. The ocular exam is probably, ophthalmic exam is probably really critical.
Yeah.
And your capillary refill time, your heart rate, and rhythm, and any murmurs, any lung sounds, pulmonary edema, anything like that.
Yeah, excellent. They're really good points because we need to look for those that target organ damage of resulting in a HCM phenotype, so good auscultation for murmur gallop? Has it gone into congestive failure? What sort of changes would we expect to see on an ocular exam? So obviously we know retinal detachment being the most common, but any others that we see on a thorough ocular exam of a cat with hypertension?
They can just go blind, can't they?
Mm-hmm.
Like, yeah.
Yeah, so sudden blindness. How would we detect that on ocular exam?
Bright light flicking into the eye and the, what do you call it, the menace?
Menace, yeah.
Yeah.
So do they lose their PLR?
Oh, I don't think they do. I don't know, actually.
So generally their pupils are fixed and dilated.
Yeah.
So different to cortical blindness, where you might still have completely normal PLRs, but no menace. Typically the pupils are really mydriatic.
And so they still have the reflex or not?
No.
No. Okay.
No. Yeah, good. Swelling of the optic disc, you sometimes see, like it looks really prominent, and really sort of tortuous vessels that you might have seen. You might see the retinal hemorrhages, but really sort of tortuous vessels across the back of the eye. And glaucoma, interestingly, is well reported in hypertensive cats. Okay, perfect. So we're going to take our blood pressure. We're going to take the context of the patient into account, and the consensus statement outlines. It's got a nice flow chart in it about if you've got signs of target organ damage present. So that could be neurological signs, CKD, as we know. So like Julian said, on bloods or urinalysis, any evidence of that. On ocular exam or on cardiac exam, if we've got signs of TOD present, we're far more likely to treat if that fits with the context of the patient, or at least repeat the measurement quite aggressively over the next couple of weeks, rather than sort of sit on it and wait and see. Because you can definitely have a patient that comes in hypertensive, you say, let's see it next week, and then it's blind next week. I'm sure you agree, Anna. They can deteriorate quite quickly. And even seizure, I know we've spoken about this before in seizures, and even Cs and worsen quite significant neurologically.
Helen, do they have seizures from ischemia, or is it seizures from edema?
Oh, I don't know. I think it's ischemic insult. Do you know, Anna?
It's edema secondary to
Edema.
alterations in blood flow. Yeah.
Okay.
Yeah, essentially neurological injury. Is it ischemia? I think I'm going to say edema.
So we've outlined, Julian, you sort of touched on it for a cat. I think what's the next page? I'm going to actually skip to this one and take that off. So blood pressure in patients that we see is very commonly secondary. So I've listed causes there, which we most commonly see. So if we think about cats for a minute, because we're going to think about the workup, CKD is by far the most common that we see, but obviously hypothyroidism is very common in clinical practice. Conn syndrome, or an aldosterone producing adrenal tumor, diabetes, and then in some cats we are going to see idiopathic. So if we're just thinking about our differentials that we're quite used to seeing in practice, Julian mentioned about he'd like a biochemistry. If in the exam we were talking about an appropriate workup for this hypertensive cat, what other diagnostics would be appropriate for a hypertensive cat, as well as a biochemistry, CBC, like you've mentioned, and why?
Oh, cardiac ultrasound.
Definitely. Yeah. We'll do an echo.
I mean, I didn't mention a T4, but you'd want a T4.
Yeah, definitely a T4. And I think, as Anna always used to say to me, just ask for a T4 in every cat in memberships.
And dog, actually. I'd
dog,
like to put hypothyroidism on this secondary causes in dogs as well. Hyperthyroidism, not hypo.
So we're going to do CBC biochem. We're going to do an echo to look for our HCM phenotype. We're going to do a T4. Maybe we could do a urinalysis for completeness. We'll ask for that to interpret our biochemistry. And as well as obviously looking at our USG to help us interpret if there's any azotemia, what else do we need to look at on our urinalysis in a hypertensive patient?
Sediment exam,
For sure. Can do a sediment exam.
Protein, maybe?
Protein. Why are we going to look for protein?
glomerular damage.
Yeah.
Helen, just to backtrack a bit, Anna's already mentioned, why is the dog hypertensive on hypothyroidism?
It's a typo. It means hyper.
Yeah.
Uh,
And the other question from previously is swelling of the optic disc can also occur with a brain tumor.
Mm,
And I've picked that up a couple of times,
yeah.
just as a differential diagnosis.
That's a really good point. Yeah, a really good point. And I guess also with a brain tumor, they can sometimes be hypertensive if they've got increased intracranial pressure. So that's an important point to kind of do a full neurologic. We should add that in, a full neurological exam if we're seeing those ocular changes. A full neuro exam would be helpful. If you all agree. Great. Yeah, so definitely looking for protein, like Julian said. That little fragile glomerular capillary bed can be significantly damaged by systemic hypertension. So protein, and if our sediment exam, like Jeff mentioned, is nice and quiet, we can run a UPC as well. What else? Because we've got this differential of hyperaldosteronism, anything else that we might like to do?
Well, electrolytes, but that would have been already looked at in your profile.
Yeah. And what changes would we see?
I think it's hyperkalemia.
So
Sodium.
yeah, high sodium, low potassium.
I always
So
get those mixed up.
I know. I always have to think of your aldosterone is increasing your blood pressure, so your body hangs on to water and sodium. So it's your sodium and water retention hormone. So if you've got too much aldosterone, you've got high blood pressure, your body's hanging on to water and sodium at the expense of losing potassium. So typically you'll see hypernatremia, hypokalemia, and hypertension as well. And they might be clinical for the hypokalemia with weakness and ventriflexion of the neck, or they might be clinical for the hypertension or be found incidentally. So definitely electrolytes we'll add on. And anything else?
I mean, you might want an SDMA already if you want if you're looking at CKD potentially.
Yeah, we can look at an SDMA for sure. Anything else to look at if they've got primary hyperaldosteronism? About where you might find the tumor, if there is one.
Ultrasound, abdo,
Yeah, to look where?
adrenal.
Perfect. Yeah, I think that would be very reasonable to add on. Let's look at the adrenals, and you can measure aldosterone as well if you so wanted to.
I'll just flag as well. We talk about hypertension with chronic kidney disease quite often, but we actually see it really quite profoundly in acute kidney injury as well. So it's sometimes hard when you've got a sick patient present with azotemia to know whether it's chronic or acute because you don't have that demonstration of azotemia over 3 months. And I wouldn't necessarily jump to chronic kidney disease because they're hypertensive.
Okay, that's interesting.
Mm.
I think that could also add weight to doing the abdo scan then to have a look at the kidneys.
That's exactly where, yeah, my thought process came from.
Yeah, that would be a nice thing to add in memberships. Beautiful. So we've got our workup for a cat. So it's kind of getting the full works, particularly an exam question, an echo, an abdo scan, full bloods, urinalysis, and we could measure lights and aldosterone if we wanted to. Dogs, very, very similar. So bloods, T4. Anna, do you think dogs get such profound cardiac changes?
No.
No. Do you think an echo would be necessary in an answer for a dog?
Um,
Not wrong.
Probably, I mean, it's not wrong, but it's also, if you said echo first, I'd probably go, do you understand?
Yeah.
Yeah. If I
Okay.
was answering, so half mark, absolute max,
Okay.
and would depend on the context of the question.
Yeah. Okay. And I think the thing to highlight with why I said all these other diagnostics is that idiopathic is quite uncommon, obviously higher in cats than in dogs, but demonstrating in an exam that you're not just going to treat the hypertension first. If they say, what would you like to do next? Don't just jump to a treatment, that actually a full workup to find a secondary cause would be really important to work through. So I just want to, oopsie. I just want to jump onto a picture of this. Can you guys see at the top here? Is this bar in the way for you as well? No. Okay, great. So we're going to talk about treatment options, but I just want to highlight this anatomy because I've got some great things that I've drawn coming up, but this is a bit neater. So just to refresh everyone's memory, we've got the afferent arteriole. So the afferent arteriole arrives is how I remembered it, A for arrival. Our afferent arteriole arrives into our little glomerulus, and it's going to go through this beautiful fine mesh network of glomerular capillaries, which are at risk of damage from systemic hypertension. This little mesh of capillaries runs next to our Bowman's capsule, which wraps around it with these specialized little podocyte cells. The cells, they obviously look like there's a gap, but these cells are wrapping really tightly around these capillaries. And as the blood arrives from the afferent arteriole, the filtrate, so i.e. glucose, water, salts, some proteins, obviously more protein if there's damage, is squeezed out of the blood capillary. We now have the filtrate entering from the blood capillary into the proximal convoluted tubule. And then the rest of the blood, anything that can't be filtered, leaves the glomerulus through the efferent arteriole, E for exit. So it exits out the efferent arteriole. And the efferent arteriole then wraps around the proximal convoluted tubule that contains our filtrate and then can reabsorb whatever it wants to reabsorb. So you can see this efferent arteriole also has this quite sort of complex network that's wrapping all the way around our tubule, round our loop of Henle, down into the medulla, back up into the cortex to do all of our resorption. So this anatomy of the glomerulus is quite important as we talk about our treatment options. So what are our three main treatment options for hypertension in cats and dogs? And then we'll talk about each of them in more detail. Does anyone want to pick one and maybe say how it works?
Helen, can we can I go back a step and just ask about
Please.
actually another step back? I feel like we've talked about this together before, but how does hyperadrenal corticism cause hypertension?
Okay. So Anna, please jump in. So hypoadrenocorticism will increase preload. It increases your blood volume. Do you remember how? It does something to ADH.
It it inc it the steroids in general affect ADH function, and
Yeah.
it increases water resorption.
Yes. So remembering, I know we've covered this in the tutorials, but remembering ADH, antidiuretic hormone, stimulated by RAS, it's going to insert more aquaporin channels into your collecting duct and cause water resorption. ADH is antagonized by cortisol, either endogenous or exogenous. And so we'd covered that term. It essentially causes a nephrogenic diabetes insipidus because your body's not listening to ADH. So if you don't have antidiuretic hormone, no, I'm the wrong way around. That would cause COPD. That's why it causes polyuria. Anna, why does it cause hypertension?
It's such a good question, Julian, and it's not actually well understood. So they think it's to do with vascular tone rather than fluid volume. And a little bit of a combination because they've got to drink more to wee more, right?
Yeah,
Like, although I do think I guess their blood volume fluctuates more than the average patient. Um, but we know that trilostane treatment doesn't resolve the hypertension secondary to Cushing's.
Yeah, that's a good point.
So they think it's more associated with the precursors of cortisol rather than the cortisol itself that contributes to hypertension.
Could it,
So things like cholesterol.
does having so if, for example, you've got cortisol blocking ADH, does that mean that ADH just keeps rising, and then could you have the vasoconstrictive effects of ADH being more pronounced in these animals?
ADH shouldn't cause any vasoconstriction, just like purely works on that collecting tubule to increase water absorption. The other strange thing that Cushing's does is actually increases or it stimulates the hypothalamus directly to change ADH secretion, but I assumed decreased ADH secretion. So it makes your kidneys more sensitive to ADH, but also decreases secretion. But neither of those explain hypertension. They explain the polyuria, polydipsia,
Yeah.
but not the hypertension. I'm going to research that and come back to you while Helen can.
Yeah, sorry, Julian. I went
Sorry.
rogue there. I was getting all excited about why they're polyuric.
Yeah, side question.
I
I
don't
feel like
know.
we've talked about this together, but I couldn't remember it in the moment.
I don't know.
The
So
logic.
Anna will get back to us.
Sorry.
No, it's so fine. Okay, so
I was just wondering on this slide, you know how you were saying the efferent arterial goes round, it's got that mesh and it all goes through. When you're in the like convoluted tubules and all that, when it's like losing sodium and all that, is it going back into that little network of blood vessels? Is that kind of
yes,
how it works? Yeah.
yes, yeah.
Okay.
So anything that needs to be reabsorbed comes back from, can you see my mouse?
Yes. Yeah.
Yeah, comes back. So it's come in as filtrate, but that doesn't mean it's going to end up as urine. So
Yeah.
much of that will then get reabsorbed into the capillary that's surrounding it, and then that will go back into your systemic circulation.
Cool. Yeah. It's quite a good visual because I've like kind of known it gets resorbed, but didn't actually think about the fact that it is actually that little arterial
Totally.
that's taking it back into.
Yeah, it's a weird concept because if you filter all of the blood, but then that all of that isn't wee, it's got the opportunity to be reabsorbed through that little capillary wrapping around it again.
Most of it.
Yeah, good point.
So interesting.
Very cool.
All right, Julian, that was the most complex non-membership level question ever asked in a tutorial. So cortisol actually has a mineralocorticoid effect. So whilst it has those effects on ADH, it also actually directly leads to like retention of sodium, and then water will follow. So we've got those like sodium retention earlier in the tubule, and then water retention later in the tubule. Oh, sorry, water loss later in the tubule. It causes blood vessel constriction and remodeling, and it activates the RAS system because cortisol upregulates angiotensin 2 receptors. So each little bit of angiotensin 2 has more effect than it would otherwise because there's double the receptors potentially responding to it.
Interesting.
So many factors.
That's interesting.
And don't blanket immediately because you don't need it for memberships.
Okay.
Okay.
I wonder if that's why they get protein urea from
That
them.
will be like the one thing I remember in the exam. I won't remember anything else.
Yeah, they're like, tell us about ACE inhibitors, and you're like, can I tell you why? Cushing's dots. Okay, so we've been over this this anatomy. So our afferent arteriole is arriving. Blood is going to flow into our little glomerular network, And the pressure in here is really important because it's the pressure within these little capillaries. There needs to be enough pressure to overcome the hydrostatic and oncotic pressure of the Bowman's capsule itself to get the filtrate through into our collecting duct. So it does need to have pressure in here. Our glomerular filtration rate will drop if this is too low pressure inside the glomerulus, but too high pressure is dangerous because it's going to damage that fine little capillary network. Does that make sense? So to maintain our glomerular filtration rate, we do need to maintain some pressure in here. We don't want to drop it too much. We just need to get the balance right between the correct pressure. We've got our efferent arteriole going out. So I'm going to just focus on 3 main drugs that we use, being amlodipine, ACE inhibitors, and telmisartan, an angiotensin receptor blocker. I know I've got a bit on here, try and ignore that. Does anyone want to talk about how any of those work? Or I can start with one.
I feel like we can see what you've got already there, so we'd just be reciting what's on your slide.
Yeah, true. I should have got rid of that. That's okay. You can explain it if you'd like for the group. Some people might listen as well and not see this in the recordings.
Sure. Well, there's so if we go amlodipine, which is probably the most common one, on the afferent arteriole, working on smooth muscle of the arterial wall.
Perfect.
And so if it's a calcium channel blocker, which allows the muscle to then relax. Does it relax?
Yeah.
To increase the diameter, and therefore the pressure doesn't pump in as hard into the glomerulus.
Yeah, perfect answer. So obviously calcium influx is needed for muscle contraction, but also we think about the tiny muscles in the vascular smooth muscle. They're still little muscles. If we're blocking calcium influx, we're counteracting that vascular smooth muscle contraction, and we're allowing vasodilation, essentially, of our vessels. Interestingly, there are different types of calcium channel blocker. Whereas obviously some can affect all of your calcium channels in different types of muscle, like cardiac muscle. But amlodipine is quite preferential for vascular smooth muscle, so it has less cardiac effects, which is why we use it so much over some of the older generation calcium channel blockers. So amlodipine is quite preferential for your vascular smooth muscle. We're going to cause vasodilation. Is it quite a potent or minimal antihypertensive agent?
I thought it was quite good, but
yeah, it's quite potent. So amlodipine is more potent than the ACE inhibitors and telmisartan that we'll talk about. So that means I'm just going to jump between these slides. I drew these, so I apologize for the drawing. Our afferent arteriole is coming in. This is in normal life, let's say. They're not necessarily equal, but a little complicated glomerular capillary bed, and then our filtrate coming down in the blue. So the blue representing the Bowman's capsule and then leaving. So here on the bottom right, when we've got amlodipine, it's going to dilate preferentially the afferent arteriole. So this is really important when we're thinking about the risks of amlodipine. So one of the biggest risks of starting amlodipine is that as we preferentially dilate this afferent arteriole, we are doing a wonderful job at decreasing systemic vascular tone and therefore systemic hypertension. But by dilating this afferent arteriole, we're letting more blood flow into the glomerulus. Does that make sense? So here at the afferent arteriole, we normally have a bit of a stopgap to kind of regulate the flow of blood into that little fragile glomerular capillaris, which we've spoken about, needs renal autoregulation to stop the dangerous effects of systemic hypertension for that really hypertensive blood getting into the glomerulus. But when we treat with amlodipine and we dilate this afferent arteriole, we are at risk of more blood coming in, particularly if the patient is still a bit hypertensive. We've now got more high pressure blood coming into the glomerulus. So that helps us to explain one of the biggest risks of starting amlodipine. Does anyone know some of the side effects that we could see?
Well, again, it was on the last slide. Proteinuria was
Yeah.
mentioned, but I mean,
Should have taken
beyond
those
that,
off.
like obviously, the iatrogenic hypotension
Mm.
is like the biggest concern
For sure.
for proteinuria. But I obviously saw the last slide, the proteinuria.
Yeah, for sure. So iatrogenic hypotension is definitely really important to talk about, particularly in like an exam setting. But this is a really important concept as to why we start the consensus statement, amlodipine is our first line in cats, because like Julian said, it's a really potent antihypertensive, and it's not uncommon for cats to have quite severe systemic hypertension. But in dogs that are particularly can get proteinuric disease, it's not our first line, because we do risk actually increasing blood flow into this intraglomerular capillary bed and actually worsening intraglomerular hypertension and worsening proteinuria, thereby exacerbating renal disease that doesn't love proteinuria, and so on. Does that make sense from how amlodipine works and why in cats? Amazing. Conversely, our ACE inhibitors, so how do ACE inhibitors come about causing this dilation? What's actually happening? Does the ACE inhibitor itself dilate that vessel? I know we kind of spoke about this before.
The ACE inhibitor, being an angiotensin converting enzyme inhibitor, stops the conversion of angiotensinogen to angiotensin 2. Is it?
Angiotensin 1 to angiotensin 2. Yeah.
And angiotensin 2 is the one that would usually cause the constriction.
Perfect. So angiotensin 2 being a profound vasoconstrictor. And as we've all learned now, it's upregulated in Cushing's. That's why they get vasoconstriction. That's our fun fact of the day. And angiotensin 2 stimulating the release of aldosterone. So we're going to get sodium and water retention. So if we're using an ACE inhibitor, we've got both the downregulation of aldosterone, so we've got less sodium and water retention. So that's going to help with our systemic hypertension. And we're counteracting the vasoconstrictive effects of angiotensin 2. And angiotensin 2 usually vasoconstricts preferentially the efferent arteriole that's exiting the glomerulus. So ACE inhibitors are going to preferentially dilate our efferent arteriole. That's of benefit. Both we're going to have anti-systemic hypertensive properties, but also if we're lowering the pressure at the exit, if we've got a high pressure environment in that little glomerulus and suddenly a little bottleneck exit that everything is trying to get out against high pressure, if suddenly now you've got a room full of people that were trying to be squeezed through a bottleneck of a small door, if suddenly now you've got a whole wall removed from the room and people can flow out of the room, we're going to dramatically help blood leave the glomerulus into that low pressure system. So we're going to drop the pressure in the glomerulus. I don't know if I explained that right. Did that make sense? Yeah. So that's really important because ACE inhibitors are have less, what's the right term? Less antihypertensive effects. They're less potent than amlodipine, but they drop this pressure, which particularly in dogs that could be that love getting proteinuric diseases, we're going to have less risk of worsening proteinuria because we don't have that same risk of the pressure in here shooting up. Because we're going to reduce the pressure, when we spoke about that you need a pressure gradient from your capillaries to overcome your hydrostatic and oncotic pressure of your Bowman's capsule, what's going to be your biggest side effects when starting an ACE inhibitor in a dog? Or in anything, I should say.
Reduced GFR.
Mm. And how are we going to see that clinically?
Worsening azotemia.
Mm.
You reading that?
Do you think all worsening azotemia would be an indication to stop therapy?
Do you not just wait and see if that corrects within 7 days? Depending on the extent of it, I guess if it's an acute injury, like to me, I would say it depends on how high it is.
Yeah.
But I think you can, if it's not many-fold acute renal injury of creatinine of 600 or something, but you see a marginal drop increase of 10 to 20%, I might just wait a week and see if it
Yeah.
corrects.
Yeah, absolutely. So the consensus statement actually say 20 to 30%. I feel like 30% is quite high. But yeah, essentially, because there are going to be a lot of benefits of starting antihypertensive treatment, we might have to ride out. So increase in azotemia, we don't necessarily need to stop therapy straight away. Just monitoring, like Matt said. What are some other risks of starting an ACE inhibitor?
Can it affect electrolyte dyscrasias?
Um,
Not,
I
not
haven't ever
really.
seen that, but I guess it could because it is interfering with your RAS. Anna, do you ever see electrolyte imbalances after starting it?
I was just thinking about potassium came to mind,
Yeah,
but
yeah. I guess there'd be a theoretical risk because it is interfering with your angiotensin too, but I don't think I've ever seen that practically, which is
mm,
good. So risk of AKI, like we've discussed. Probably another iatrogenic hypotension, like Matt said, we definitely list. Probably something that we do see is it's not potent enough, particularly in cats. I don't know if you guys find that in practice. So it's really modest antihypertensive. The other thing that you can see is does anyone want to explain? I know we've touched on this in a tutorial before about what we mean by aldosterone escape or ACE enzyme escape. People call it different things.
I vaguely remember this from the tutorial.
Yeah.
Haven't refresh. Was it something that there's like another layer of the cascade that starts triggering, like it's gets upregulated, like a part of the process that Julian referred to, that there was like another effect somewhere else that would be that that comes into play,
Yeah,
like
absolutely.
a receptor fight back.
Yeah, so there are alternative pathways. There's different kinases and different pathways that angiotensin 1 can be converted into angiotensin 2. So an ACE inhibitor, people refer to that as escape. An ACE inhibitor isn't sort of just set and done. You definitely can have conditions where it's not enough, or actually it's not enough to overcome because the patient has other pathways to still produce angiotensin 2 and have all of those effects. So they're definitely patients that need ongoing monitoring. One drug that in theory could get around that would be an angiotensin 2 receptor blocker. So the most common that we use being telmisartan. So having the effect at the receptor level, because then it doesn't matter how much angiotensin 2 is produced. If anything, the amount would actually go up because it's being blocked at a receptor level, but you still, in theory, have the same effects that you're downregulating aldosterone and you're preferentially dilating the efferent arteriole. The other thing that's interesting about telmisartan, as well as blocking at the receptor level, is it's thought to have a protective effect on the podocyte function. So there's a receptor that helps those. I can't remember exactly what it does, but I think you probably wouldn't need to know that at membership level. Anna, correct me if I'm wrong, exactly what the receptor is, but telmisartan can protect those podocyte cellular function, which means it's also helping to maintain essentially the integrity of that Bowman's capsule. So it might be better for severely proteinuric patients because you've now double whammying, helping to reduce the pressure in here and reduce that squeezing of the proteins across into the filtrate, but also protecting those little cells that can be damaged.
Yeah, I don't think you need to know the receptor for
Oh, okay, that's enough detail.
Yeah.
So for that reason, telmisartan, although it's like an ACE inhibitor, it does have quite modest antihypertensive effects. It would be a potentially really good choice when we're dealing with systemic hypertension and proteinuria. And you'll see in the consensus statement. And also there's another one for memberships about there's good guidelines on proteinuria, why they'll sometimes jump to, people recommend jumping to telmisartan for severe proteinuria because it's got that nice protective benefit. Telmisartan is obviously is good for proteinuria in cats, but again, like an ACE inhibitor, it's minimal antihypertensive, so it's not really enough as a first-line agent in cats that we'll use amlodipine for. But because of those risks, risk of AKI, dropping the intraglomerulus here, and risk of actually worsening intraglomerular pressure and proteinuria here, that's why we'll use amlodipine first in cats, ACE inhibitors in dogs, and then add on or combine if needed. Remembering that the caveat to that would be dogs that are in a hypertensive crisis that are like over 200. That might be when amlodipine would be a good choice to jump to straight away, potentially in combination, if we're not too worried about renal function. So I think those drugs are probably very examinable and why you'd use them and sort of comparing them. Does anyone have any questions about that for myself or Anna, if I can't answer it?
Sorry, I think you just touched on this, but did you say in the consensus statement, which I haven't reviewed, that for proteinuria in a dog, that ACE inhibitors are first choice before telmisartan, or did you say that that it said jump to it if there's like podocyte, you want to protect the podocytes and have a bit more of a broad spectrum effect, or if it was a higher degree of proteinuria, you might jump to telmisartan straight away?
Yeah.
Yeah.
Yeah. So typically, like with glomerular injury, and you're getting a UPC about 7, 8, 9, we would use telmisartan straight away. Do you agree, Anna?
Yeah. So yeah, typically if we've just got proteinuria with no hypertension, I would typically use an ACE inhibitor just for cost effectiveness. As a first line, if there was low grade proteinuria, but if there's high grade proteinuria without hypertension or proteinuria of any kind with hypertension, telmisartan.
Yeah, thanks.
Okay, so we've spoken about those, and you can add on. We've spoken about worsening renal disease, potentially worsening proteinuria. I've put this in a random place, but anyone studying memberships, I feel like it would be quite a horrible question to discuss the ocular findings of hypertension, but I don't see why it's not examinable. I just had a cat the other day and I was trying to explain the lesions to someone. I found this paper. Anyone that's listening, if you just Google hypertensive ocular disease in cats, and it's got the most amazing pictures of fundic lesions in hypertensive cats. I hate ophthalmology. I'm sure you all do if you love medicine. And I found this paper really helpful. And it's open access. I found it through the ICC website. Great. So monitoring, I'm going to come off of that so that we don't just have it. Anyone have any thoughts about how we're going to monitor these guys in practice? I know it massively depends on their underlying disease, but a few broad principles.
Can I just ask a question, just going back a step, sorry, but so if you've got a cat that's hypertensive, but it's also proteinuric, would you start it on amlodipine and your telmisartan at the same time? Just go for it? Yeah, okay. To know.
Yeah, you could definitely. It depends a little bit on the case. Like if you're worried, what you're worried more about, if that's not a silly thing to say. So you wouldn't necessarily have to start them both at the same time, although you definitely could.
I mean, if it was a minor proteinuria, could you see what would happen if you correct the hypertension to see if the proteinuria resolved with the hypertension?
Yeah, that's true. Yeah.
Is that likely to happen?
Do you agree, Anna?
Yeah. So the answer to that question would be it depends on the degree
What's
of
going on?
hypertension.
Mm.
A lot. So, I mean, if they're over 200, have everything. But I'm really worried about that patient. If they're sitting at 165, I'm probably going to go, let's like try telmisartan because the proteinuria is probably as much of an issue as the hypertension at the moment. Does that make sense? It's very vague, but
Yeah, no, that's true because you're just trying to figure out too whether that proteinuria is because it's been pushed through so fast or whether
exactly.
you've actually got issues with the
Yes.
kidney.
The
Yeah.
good thing
Yeah.
about the exams is I don't think they'd give you a vague case. So I don't think they'd say,
Mm,
like, in a hypertensive cat, do you want to do this? If they want you to say, what are you most worried about? They'd probably present, here is a cat in a hypertensive crisis. You know, a cat presents with acute blindness, blah, 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 blah. Or make it quite, so that is a hypertensive case they're examining you on, or it is a proteinuria case that you're examining on, and that's our main clinical concern. And then they chuck in that it's mildly hypertensive. I
mm.
think they wouldn't try and trick you. I think they'd present it where you're kind of guided what's the most important disease to be focusing on. Do you
Cool.
agree?
Thank you. Yeah, it's
They
reassuring.
could potentially say, like, so the question's not going to be clinical and then be ambiguous about which would be the right thing to choose. But a question that I would probably ask is discuss options for management of hypertension in the cat, including mechanisms of actions and situations where you might lean towards one or the other. So discussing like the pros of telmisartan in the context of proteinuria kind of thing. But if I was writing the question, I would say include in your answer these situations to be really specific about what I wanted. And then you know that.
Cool.
Yeah.
Thank you. That's cool.
Cool. Um, Broad principles for monitoring. If the question was about, I know it depends on the context of the case massively, but just generally speaking, what should we do? Let's
Repeat
say it's a
urine
cat.
protein to creatinine ratio, blood,
Perfect.
like renal parameters, blood pressure.
Perfect.
Here, like clinical signs of general tolerability, vomiting, compliance would be a big thing for the cat for me.
Mhm. And so say that we start treatment on day one. When do you want to repeat those things? So you mentioned UPC, repeat blood pressure, clinical signs. When do we want to repeat those?
I guess I'd probably say BP, maybe like depending on how acute it is. If it's sub 200 systolic, I'd probably say 3 to 5 days recheck.
Yeah, I think that's really fair. Kind of anywhere in that 3, 5, 7 days
And if
recheck.
if I was comfortable to move it to 7, that's when I'd do the renal parameters.
Perfect. Yeah. So we're going to recheck blood pressure. And as Matt touched on, it does depend on the degree. So if you've got a really hypertensive cat, we might even get that cat back in 2 days' time. And if it's systolic 240 and it's got target organ damage. And I think in the question, like Anna said, they wouldn't leave it ambiguous, but referring back to whether you know if there's target organ damage present, helping to guide your decisions is something the consensus statement really focus on. So if we've got target organ damage, we're going to be a bit more aggressive about seeing him back. We're going to repeat renal enzymes in 7 days, particularly because of that risk of renal injury. We're going to monitor and repeat UPC and monitor and repeat blood pressures. You don't necessarily have to do all of them every time. You might, see them back for blood pressures more than repeat tests. But
And then with animals that are not really amenable to good blood pressure, I mean, I guess if the UPCRs improved, maybe it's used as a bit of a sentinel in some patients.
yeah, I think that's a fair point, particularly if proteinuria is kind of predominating the clinical disease that you're worried about. Then there's good guidelines for treating proteinuria, like getting it back down under 2, or at least reducing it by 50% if you've got a marked proteinuria. That would be a really good thing to aim for. Yeah, you're quite right. And it's nice because especially if you're collecting it the same way each time, which we should do, if you've always done it as a free catch at home with a really nervous patient, that would be a good way to monitor.
On that point, is pooled 3-day UPCRs recommended over single day UPCRs?
Yeah, it is. I don't always do that, I'm not going to lie, but it is in the guidelines. So do as the guidelines say.
Mhm.
I would absolutely do that. We make like pretty big clinical decisions based on the
That's a good point.
UPCR, and it just fluctuates so much over the
Yeah.
course of the day. If they're postprandial, if they've just been resting, that there's so many causes of fluctuation. We know that in the morning cortisol levels are higher, blood pressure is generally higher in the morning. That's going to alter our UPCR. So I really encourage the 3 samples, even if it's 3 samples over a day rather than 3 days.
Mm.
Just pull them.
Yeah, I found a big difference
Huge.
moving to that.
Yeah.
Yeah, that's an important point to highlight, Matt. Yeah. Any questions about blood pressure stuff? I'm sorry, I've spoken about that for the whole hour, and we were going to do some questions on pericardial disease, so we might have to save that for another time.
Well, why don't we, because the next 2 sessions are membership practice, right?
Yeah.
Is that right? Yeah.
Yeah.
So why don't we just chuck a pericardial question in
Yeah.
there and make sure we review it?
Now everyone can go and study pericardial effusions for 2 weeks and
Know exactly what's coming.
does anyone have any like burning questions about hypertension, or feel like there's anything I haven't addressed that that's come up in your learning, or anything that you want to ask? Feel okay about a question that was like compare and contrast treatment of hypertension in cats and dogs, something like that? Good.
Julian's looking confident.
Yeah, good. I think this would be a cool exam question because there's a lot of like little bits to talk about how they work and why we use them for cats and dogs. So
yeah,
great.
Thank you so much, Helen.
Thanks for
thank
joining,
you.
everyone.
Thank you.
Thank you. It was really fun. It was good to be able to join.
Yeah,
You're
great to have
welcome.
you, Olivia. Thank you for joining.
Thank
And
you.
Thanks so much.
Can
Thank you all.
you just stay there for a bit? I've got something to talk to you about.
Yeah, sure.
Bye, guys. Bye, Jeff.
Bye, Helen.
See you in 2 weeks.
I'll just stop recording, Jeff.